Okay, we'll try it again. Perfect. So, welcome to Saturday. It's our last day of our Facebook Lives for National Infertility Awareness Week. I am so excited. We get to have Morgan Mayo. She was one of my nurses through my infertility journey, and she's just amazing. And I reached out to her, and she was willing to join us today. And then this evening, we're having Dr. Kane, and she's a reproductive endocrinologist at Sanford Fargo. So we have a really awesome day with a medical perspective into infertility. There it is. Add. Perfect. And if you have any questions, you can put them in the comment section or send a message, and we will try our best to get them answered.
Yay! Oh my God, that was so hard for me. I don't know why I'm retarded.
Every day. No, don't. Every day there's been something. It's just, I'm like, yeah, I troubleshooted this or did this.
Jeez, yeah. I was like, I don't know what I'm doing. I've never done this before. I'm like not technology savvy at all.
I'm not either. The first night, it was chaotic, and I actually had to stop it, and I called my techie friend. I'm like, oh my gosh.
Like, what's going on?
What do I do? Yeah, this is not my thing.
You think I'd be way better at this, being a millennial and all, and I'm not.
It's just not something medical people care about. There's people who care about it. It's not us.
Very true. Yeah.
Awesome. Well, thank you so much for joining me. I was just my journey. You were my nurse, and you were just wonderful. And nurses are such a huge part, I think, of this whole process. So we had kind of talked about some things we're going to talk about. So first of all, what made you want to be a nurse with the reproductive endocrinology group?
Yeah, so I actually have a background in cardiology, so way different than reproductive and IVF. I actually dealt with mostly old people. And then one of my doctors, his wife was an REI doctor, and I babysitted her kids, and he kind of just brought it up to me. And I think always in my nursing career, I wanted to go to women's health, do something along those lines. And so this presented itself, and just kind of got introduced to it and fell in love. I think it's a huge thing that's definitely becoming more relevant. It's becoming more out there, and women aren't so terrified about talking about it, which is huge. I love this infertility uncovered kind of thing, making awareness to it, because I think it's still things that people need to talk about. A lot of women are still ashamed or afraid, or they don't want to admit to what they're doing, and it is a disease. It's nothing to be ashamed about. It's with everything else, which also I think is huge in getting coverage and things like that, because it's not, I don't think it should be something where it's elective. It's not no woman chooses who wants to have a family. No one chooses not to want to be able to have kids naturally.
Exactly. So along the lines, coverage, does that affect how people come to you or choose their treatment, or do you ever have to revolve things around if somebody has coverage or not?
Yeah. Well, unfortunately, there's not a lot of people that have coverage, which is one of the biggest, I think, blockers when women or couples try to come in. And it is one thing that I think a lot of people aren't able to do treatment sometimes, is because it is a huge financial burden. When people do have coverage, absolutely, it's, that's a huge stress off their plate. They don't have to worry about what clinic they can go to, what they're doing or medications. It's just, let's go hit the ground running. Of course, because IVF has such a higher success rate than cheaper things like IUI. Also, on the clinic I work out, we're pretty expensive. So I feel like that times two, maybe defer patients to go somewhere else, or they might not want to travel because of the travel expenses. But absolutely, I mean, it's huge. And a lot of couples I've had, they can't do IVF. So they are trying to save money or do second mortgages on their house. And it's, as a nurse, we try to do the best we can. We try to get medication coverage or, do whatever. But it's hard. There's a lot of stuff that we can't do. And it's super sad when patients, they can't go with IVF just because of the financial burden.
Right. Do you see people take breaks? They come to you for stage 1, maybe medicated or IUI, and they're like, we have to stop, take a break because we have to recoup our finances?
Yeah, absolutely. I see a lot of women or families that are like, we need to save up. So hopefully we can save up in the next 6 months, and we'll try. The only bad thing about that, which of course it's something they have to do, is a lot of women times of essence, right? So as every month, and they feel that pressure too, and that puts stress on them. They feel like every month they're just getting older and older. So I hate when couples have to do that. But yeah, absolutely. You know, they'll say like, you know, we are saving up, we're going to try to like save for the summer or do whatever needs be. And then they try to come back and like do that, do IVF if that's the treatment, of course. Of course, a lot of couples, when they come to us, we don't really know exactly what they need to do yet. But if IVF is like what we're recommending, a lot of times when we recommend like spending money on doing IUIs or doing things like that is if IVF is going to be the best choice.
Are people open if you ever like, hey, I got to go sell a car, refinance my home, ask family for money? Like, what are some crazy things that have come up in that sense?
Yeah, my dog says hi. Yeah, I feel like it's once you get a relationship with the patient, which of course, you know, you can probably speak with that too,
Yeah.
as you know, as you start learning nursing, you feel more open. Absolutely, I feel like the first thing they don't tell me is like, I gotta go sell my car for this. But as they go, you know, they'll be like, do you have any like programs? So we're always, I'm the little thankful my clinic is really good about like talking about there's programs to apply for, or you should apply for this grant, or you know, there's just medication coverage to do. But yeah, a lot of couples are like, you know, we're doing this, we're asking for money, we're starting a GoFundMe page, you know, absolutely. Just because it is, I mean, I don't know, I couldn't afford it. There's no way I could. And I work at a fertility clinic. So
Right.
yeah, absolutely. But I definitely think as they get more comfortable with you or your nurse or your clinic and things like that, they're definitely more open about that journey and how they got there. But yeah, sometimes as a nurse, I don't even know. They don't tell me one thing just because it's, you know, maybe it's, you know, personal and they don't want to like, you know, divulge that information. But I think it just depends on the relationship they feel with their nurse and with me
Right.
probably personally. But yeah, a lot of women are like, this is something we can't do right now, or especially when they meet and then meet the doctor and they're like, IVF is the way to go. Then I'm like, okay, the first thing you need to hear, we meet at the business office because they're going to get that sticker shock price tag. And, you know, it's a shock. And I don't want ever to
Right.
misguide, you know, mislead someone and what they're about to experience. So definitely, I don't think maybe as people talk about it more, they're going to realize like IVF is expensive, but some people don't know actually how expensive it can be, or they'll look at the treatment and don't know medications can cost another 5 to 7 grand, or just like the
Yes.
other expenses that you don't think about when you get that initial price tag.
Right. And you had mentioned there's some grants and programs available, and I know a few, and I'll try to post them on our page. But
Yeah.
yes, options like that and asking your clinic if they know of any, I think is really important too.
Yeah, absolutely. And I do know, I mean, like, especially for medication, like compassionate care and reunite, you know, you can get up to like 75% off your medications, and it takes like a 5-minute process to apply for, and you get a response within 2 days. So you push that. And I do know there's like national infertility, like grants that offer like scholarships, per se for couples. Like they do that stuff all the time. So just like literally Googling like, you know, grants or scholarships and things like that. There's a lot of programs out there that pay for cycles or help do that kind of stuff. Or I've had couples who, you know, have success and they come back and they're like, we want to give back. What do I do? And I'm like, well, there's, you know, donate to this program, or there's a scholarship fund. And so there's things like that that people want to give back. So there's definitely options out there for sure.
Awesome. So let's talk about. I know one thing we talked about was like the lifestyle. What are like
Yeah.
some things people can do on the side when they're diagnosed with infertility to kind of help with treatment, make either improve treatment success outcomes possibly, or just to help keep them mentally and emotionally in check with everything.
Yeah, so huge thing. So one, I think that, you know, the study says that women who go into infertility, they get on Dr. Google, which is not a bad thing, but also I feel like there's a lot of misleading things out there.
Yeah.
So definitely we just encourage like a healthy, well-balanced diet. There's no diet out there that's going to improve your chances. Definitely eating like healthy and having a healthy BMI, so not being extremely overweight or way underweight, can definitely help with that. We're really positive, encourage anything that's to help reduce your stress. Not saying that if you're stressed, you can't get pregnant, but there's huge studies out there. Alice Domar is someone we always like. She's a counselor out of Boston IVF, and she wrote this huge study that's saying that women who undergo like mind, body, exercising, so like acupuncture, meditation, you know, group therapy, they have a 15% chance of more success. So we always encourage that. Of course, it's impossible to tell a woman who is wanting to get pregnant, who can't get pregnant, not to be stressed. So we just tell them to do
Right.
whatever you can. So acupuncture, we are very pro. You know,
Yeah.
there's studies that show it helps even just relax you, but also helps improve blood flow, things like that. You know, meditation, we're all about that. I think group therapy is great. Going through this with a group of women who like know what you're going through is huge. With that being said, too, also you can't compare what you're doing to what someone else is doing because your protocols and medication and treatment is going to be different from patient to patient. But it is good to go through things like that. So we love that. As far as lifestyle, we recommend decreasing caffeine and alcohol. Of course, smoking, tobacco use can severely decrease chances of success significantly. So definitely cutting out any tobacco use will help, definitely help. What else? Supplements. There's always there's a good supplements women are on that help. Now, of course, you can Google and get on 100 supplements. They're just going to help minutely, but stuff like that. So you always want to ask your clinic. Most clinics have a cocktail list like we do at our clinic of supplements women can be on to help maybe improve that egg quality, egg function a little bit. So definitely I would always talk with your clinic about that or talking to them and seeing if this is okay. Acupuncturists usually always have some stuff too, but that also can be a little tricky because some acupuncturists recommend really crazy Chinese herb supplements and stuff that your clinic might not be okay with. So just make sure whatever you're taking, that you talk with your doctor or your nurse and make sure that they're okay with. But yeah, taking care of yourself. Whatever you do is going to help you get through this and help you stay positive and try to decrease that stress level is always going to be beneficial for sure.
I was thinking it can't hurt. I mean,
for
you're
sure.
supposed to be healthy anyways. You should do this stuff. I meditate every night while laying in bed for 10 minutes with a guided meditation because my day, or just because I want to just clear myself in the day. I just think it's good, healthy practice to do some of them.
Absolutely.
Things. And I know there's actual research supporting acupuncture to improve blood flow. So
absolutely. Yeah, we actually, we do acupuncture. I don't know if you did this with you, but when you were transferring with us, but we do acupuncture before and after our transfer.
Yes.
Yeah, because it does help with that blood flow. I mean, there is scientific data behind it. If not, if all else fails too, it'll help just relax you. So we're very pro that. Now, with that being said, if you hate needles or something that if it's not going to relax you, it's not going to be your make or break, but if it's something that you're open to, we're very pro it for sure.
Yes, and I know someone who's it was fight or flight, when they had the needles in, and then it got better. I don't know if anybody rip the needles out. I'm sure it's probably happened, but they're so tiny. It's nothing. Just
they're
just
super small. Yeah, and we you know it relaxes. Yeah, so I think once you get over the first initial shock of putting needles in your body, I've done it for therapy on my knee and stuff and love it. And so I mean the science behind it makes sense, but anything that's nothing can really, there's not a lot of stuff that you can do that is going to hurt your stuff unless it's, doing smoking or stuff, but anything else, the small minute changes can definitely make a big difference. And overall, if it makes you feel better and you feel like you're doing something, I feel like that's huge. A lot of women, they feel like they don't have any control over this cycle or their process. We're kind of changing a lot of stuff. So if they can control a little aspect of this makes me happy, or I'm going to have this little bit of control, it definitely helps too.
Right. Supplements. So top 5 supplements. I'm into CoQ10.
Yep.
I believe, and I've listened to a different reproductive endocrinologist talk about 600 milligrams, I believe, is recommended. Fish oil, antioxidants. I'm a vitamin C person, year round. I mean, the vitamin C flowing and vitamin D. Those would be my top 5, I think, if I was.
Yeah, those are all
cocktail list or whatever.
Yeah, for sure. Yeah, and that's another thing too is we check with vitamin D. We check a vitamin D level because low vitamin D can interfere with implantation and stuff. So it's definitely huge to get that checked and then to be on it. Definitely, like you said, CoQ10 is huge. It probably has the most studies is out there as CoQ10. It's probably been around the longest. Vitamin C, vitamin E, vitamin D, all those are absolutely great. Fish oil is great. A lot of prenatal should have DHA in it, omega-3, same thing. If not, it's also great to add that in for sure.
Wonderful. And us in North Dakota, I just stand the vitamin D year round.
Love it.
Out of the year, we don't get 300 days of sun. It's just take it every day.
Yeah,
I do 5,000 units a day personally. I mean, you can't get too hot, in my opinion.
Yeah, so,
living in North
and you'd be
Dakota.
surprised, even people who live in California, who have sun, in San Diego, they have low vitamin D. So you'd actually be surprised.
Yeah.
I would say most of my patients come back borderline low. It's very rare for patients to be very super, super low, but most patients are not, they're in the 20s, which is we want to be 30 or greater. But I would say majority of my people who check it, they're on that border and low. So it just doesn't hurt to add it in with your stuff for sure.
Wonderful. So let's say someone decides, all right, we're going to start with reproductive endocrinology. What can they expect at their first appointment? Or what does a first appointment typically look like?
Yeah. So first appointment, if you're coming in and, you've had, let's say, haven't had been able to get pregnant and you're obese, and go see a doctor or REI doctor. So we walk in the clinic, you're going to do kind of what we call basic workup. So that's going to include, biggest thing is going to be blood work. So it's going to be cycle day 3 blood work and an AMH level. An AMH level looks at your ovarian reserve, and cycle day 3 blood work looks at your ovarian quality. So we think your egg quality is. That is blood work that is cycle dependent and is usually done on cycle day 3. So cycle day 1 is like the first day of your period. Day 3 is when we have those labs drawn. Then you also want to have a baseline ultrasound to look at your resting follicle count. We also refer it to an antral follicle count. So basically how many eggs you have on your ovaries. Gives us a good idea of what we're looking at, if that number is low or high or where you're supposed to be. Also want to do an HSG. An HSG is where they inject dye into your uterine tubes or to your uterus to look at your tubes and make sure they're open or patent. It's pretty surprising. I have patients who have had failed cycles elsewhere and they've never had an HSG. Well, if your tubes are blocked, there's no way. I mean, that's probably problem number one. Like the sperm's not being able to get and fertilize that egg. So huge ask for that too. And then at our clinic, we do what's called an office hysteroscopy. That's where we put a camera inside the woman's uterus and look inside to make sure there's no endometriosis or polyps or fibroid, anything that's in that uterus that could interfere with implantation. Also, of course, that's all the women's side. There's also the male side. So we also want to check that sperm. We want to look at sperm count, so how many sperm there are, how they're moving through motility, how they're shaped, which is a morphology. And we also look for anasperm antibodies to make sure there's no antibodies that can actually attach to sperm's heads and kind of block that fertilization from happening. So kind of looking at both. So that's kind of basis one. Or does everything look fine? Do you have diminished ovarian reserve, which means you have really low egg count or poor egg quality? Is there low sperm count, low sperm quality? Or is it something easy like a physical abnormality? You have a blocked tube or you have a polyp or fibroid in your uterus. So once we can kind of figure out if we can figure out the problem, especially if it's a physical abnormality, you can a lot of times do surgery, find that, fix it, and then we'll say, okay, go try for another 3 months. A lot of times if it's something physical, like something easy and everything else matches up, then women actually don't come back to us, which I'm assuming they hopefully get pregnant. Now, if it's something where there is low sperm count or low egg count or something in that matter, then that's when we decide, whether try IUI, which is intrauterine insemination, or if it's really bad. So let's say really bad sperm counts or really bad egg quality or counts, then we might say just go forward to IVF, just to improve chances of success. We always give the option. Patients can always try IUIs. It's not that we don't want to say just go to IVF, but just a lot of times if their chances of success are very diminished, we tell patients you can try 1 or 2 cycles, but your chances of success are going to be low, and IVF is going to be your best option. But yeah, just giving this kind of basic workup. I always tell women and my friends too, if they're having having unprotected intercourse for 6 months, they're timing their surges, things like that, and not getting pregnant, then go get checked out and just get a basic workup. Just make sure everything's still going fine.
Right.
Another thing too, we also do, it's called a monitored cycle. Basically what happens is we want to make sure that you're ovulating correctly. So we'll tell women, to start checking for uterine a surge using the ovulation predictor kit. And then most women, let's say if you have 28-day cycles, you should ovulate by cycle day 12, 13, 14. Now some women, they may not have normal cycles, but you're never really ovulating on time, or you're never really producing an egg to release. And that's also something we can fix simply with like an IUI or like Clomid or something. So just making sure you're ovulating too, because some women don't even know when they should ovulate, or that you only ovulate for a certain period of time. And if you miss that time, you miss one day, then you miss the whole month. So sometimes it's just helping time out their cycles, telling couples when to have intercourse, when to check for things like that. Sometimes it might be a simple solution.
And that's what I'm like, okay, simple people, like with insurance coverage.
Yeah.
Basic 101. We're not walking in saying, hi, I'm here for IVF. Like, it's like the statistics, like 1 in 4 actually need, more, they only need basic care. It's not like
absolutely.
Someone's walking in seeking IVF. It's simply like people don't even know they're not ovulating.
Mm-hmm.
And it's a
simple.
fix.
Yeah. And especially, like I said, unless you're like finding that, you really, women ovulate and then you have like a day window to have intercourse to hopefully help fertilize that egg. So if you're, unless you're having intercourse every single day, then there's very chance that you're just missing that, yeah, like who has time for that?
Work.
But yeah, I mean, it's just like finding that, like sometimes it's easiest out, our first option is never IVF unless that's just where we need to go. We want to try to hopefully find the simplest way to get you pregnant if there's just something as easy as education, like timing out cycles. Again, you'd be surprised by, women who come to us and they're like, I don't really know when I ovulate. And I'm like, well, let's just talk 101. Like, this is what you do, when to check for your surge, and then when to have intercourse. So a lot of times it's a simple, easy fix like that. Absolutely. And a lot of times, if you have insurance coverage a little bit, like your OB's office a lot of times can do IUIs. So if you have a little bit, so a lot of times like it's something that your OB can maybe do. With that also being said, I tell women all the time that their OB you don't want to be at your OB's office for 6 months doing IUIs. If it's taking that long, you need to go see someone who's experienced in reproductive stuff. So it's a fine line too.
My big tip too is I believe if you do more than 3 IUIs, your chance is like less than 5% for success.
That's correct. Mm-hmm. Yeah. So we say like our IUI number 1, if everything looks in, you have like a, let's say 40% chance of success, and IUI number 2 drops down to like 20, and then IUI number 3 is could be like less than 10. Because if everything's timing up and we're doing IUIs, something else is going on. That's why we're not having infertility. Not that you can't get pregnant on your 3rd IUI, your 4th IUI, right, but the chances of success are going down because if we're timing everything else up, where you're ovulating, we're putting sperm where it needs to be, something else is happening. The sperm's not fertilizing the egg. You're not implanting in your uterus. So something else that needs to be done.
That's a really good explanation to why, like you said, it's not like you might not get pregnant, but there's something more medically behind the reason.
Yeah, absolutely. And that's, again, we don't want to just spin your wheels or, waste your resources, your time, energy, money, things, right, with IUI. If it's just, your chances of success aren't going to be that great.
Right. So beyond IUI, when you move into IVF, what can they expect? Like, what is, okay, however, whatever's been done before, what can they expect day one when they're like, we're going to start IVF?
Yeah, absolutely. So one, it's going to be super overwhelming. So that is completely normal just to feel that overwhelming sense of you're hooked up to a watering hose and just taking information. But hopefully we can take it step by step. So usually if we already done workup, IVF's the way to go. Then a lot of times you'll be put in a calendar, basically what that is. So depending on what you're doing, what kind of calendar is, if you prime or not prime, it kind of all depends. But basically when you're in those injections, what you can expect is one, you're going to be on hormones quite significantly. A lot of times you can be on one injection a day to up to 6 injections a day. Most of them are subcutaneously, which means they go in your stomach area. They're pretty small needles, but we do our injections like morning and evening. So you're like 2 injections a day. Also in that process, you're going to have frequent labs and ultrasound. What we want to do, that medication is going to make your eggs grow. So normal women, normal cycle, you grow 1 egg, it ovulates, and then if you don't get pregnant, you have a period. With IVF, we're going to basically prevent you from ovulating on your own, and we're going to grow as many of those resting follicles as possible. So let's say if you have 10 resting follicles on your ovaries, we're going to try to grow all 10 of those follicles. The follicle is an egg. So you're going to have those frequent labs and ultrasound to monitor that progress and how you're responding to those medications. So you can have, 5 to 10 ultrasounds within, 5 to 10 days. So you're going to be seen quite frequently at your at your REI's office to monitor that and for labs and ultrasound. And then once your follicles are mature, so once your eggs are mature, then you'll trigger. So basically we'll make you ovulate, and then you'll go for IVF egg retrieval. Now, what that consists of is a lot of times you're under anesthesia, so you're completely asleep, and we go extract those eggs from the follicle, so basically suck out those eggs. It takes about 45 minutes or so. That's how long ours take. I mean, it could change from clinic to clinic, but you're under anesthesia the whole time. And then afterwards, you go to recovery. Most women, I feel like the next day they're able to return back to work. Might need a day or two. Anesthesia is just IV sedation, and that's what we use. So you're pretty with it. Afterwards, might be a little loopy or tired. But again, most of our patients travel home the next day or go back to work the next day. And then after the eggs are extracted, we fertilize the same day. And then depending on what you're doing, whether a fresh transfer or a frozen transfer or genetic testing on the embryo, and that kind of can change that, what that looks like as far as when you're going to implant the embryos back in.
And those are the 3 options: the fresh, frozen, or genetic testing.
Exactly.
Then they
CCS,
later.
Yeah. Exactly. Yeah. Yeah. So those are the three, and all depends on, definitely what you're doing and, your age and your history of what your doctor is going to recommend doing, whether
So,
fresh or frozen, can definitely vary clinic to clinic. At our clinic, we mostly do frozen transfers, but we do that CCS testing quite often. But I definitely think that doesn't mean if you do fresh transfer, it does not mean it's a bad thing. It all depends on you individually, what your doctor's plan is for you, and kind of where you're at in your fertility journey.
wonderful. Did I miss anything? I know we kind of talked a little bit. That's like we're doing very basic 101 high level
Yeah,
overview of everything because there's so much that goes into and so much personal. Like, because one person with the same diagnosis of you can vary due to many reasons too. So, not like you
absolutely.
said, I think it's important to not compare yourself, not compare protocols, but
For
one thing
sure.
everybody should be doing is that, like we talked about earlier, just mental, physical wellness overall throughout your journey.
Yeah, absolutely. I think that's so huge too. I stress to my patients all the time, is it's super overwhelming. But the biggest thing is your nurse or whoever you're talking to is like that direct contact between you and your doctor.
Yeah.
So use her or him, use them, ask them all the questions you have. I get so upset when patients are like, I don't know what I'm doing. I'm so frustrated and I haven't heard from you in, 2 days. I'm like, you got to call me. Like, I don't know
Oh,
if you don't know what's going on too. So I
yeah.
promise I'd rather a patient call me 100 times a day, and ask me the littlest questions rather than like just be afraid to call your nurse. That's what we're here for. We're here to help you out through that. And like you said too, that yeah, taking care of yourself, it's super huge to like take time for yourself and what you need, whatever it needs to help you feel better. Take care of your body, yourself, your mental status, your physical status, things like that is like so huge because it is an emotional draining process. Absolutely. I mean, it's draining in all counts, like physical, emotional, financial,
Yes.
but
I've
definitely whatever the little things you can do. Yeah, absolutely. And talk about it. Like I
yeah.
said, talk with your friends. And again, the one thing's huge. Like if just because your friend is doing this medication, ask your nurse, like, should I be doing this too? And there's probably a really good explanation of why you're not doing what your friend's doing. But it's also huge too, like get that support group, get your support team behind you,
Yeah.
and talk about it. I think that's the biggest thing that's really cool. As when I started 6 years ago to like now is like how prevalent it is now. Like TV shows are talking about it and movies are talking about it.
Yeah.
Like it's just becoming more out there, which I love because it should be something that we're not ashamed of or should be embarrassed of. It's again, it's something that it's a disorder that we have, and I think it's important to talk about it and get the awareness out there because that's what's going to change. And like you're doing that stuff, that's the only way that things are going to change. Laws are going to change. Coverage is going to change is if
Yes.
people start talking about it.
Yes. Like I said, it's a disease and it needs to be covered. And
Absolutely.
like it is not, we didn't ask for it. It's nothing we did or
No,
didn't
like
do. It's a
yeah.
disease. Like,
I hate when it's like it's elective treatment. I'm like, but what woman electively doesn't want to be able to
right.
get pregnant naturally? Like, and I totally
Right.
understand that. Like, we feel like we are made to get pregnant and have children, and when we aren't be able to do that, like the feelings that come with that, I can only imagine. But
Right.
that's why it's again something that no one would ever wish upon anyone else. Like, no one wants to go through IVF or go through IUIs. Like, who wants to
Right.
do that?
No.
But it's
No.
not something. So I hate that term, and I feel very confident in the future things will change, or hopeful that in the future, as we talks about it more and people will keep doing like what you're doing, that this is going to change.
Right. And the one last thing I want to end with just is like why I had a nurse too is ask them any question. Don't Google, don't
Yeah.
compare,
Uh,
just contact
Dr.
your nurse. Their
Mhm.
job. They don't care. Like
Yeah,
whatever form of communication your clinic requires, just use it. Even if you do have a question about, well, this person, like you said, is doing this or that or whatever, just ask. And if you
absolutely.
saw some new available test or treatment, just ask. Like
Yeah,
simply ask and
absolutely.
go to your nurse.
We don't get mad. I mean, I think it's awesome. Like, be proactive in your treatment. And yeah, if you have a friend who did something or something you heard of this new study, or definitely
Right.
talk with them. And a lot of times they're going to be open, or there's going to be explanation. Yeah, definitely. Again, talk with I love my patients ask me all the time, or again, I'd rather them ask me 100 questions in a day than not ask me anything, because that's what we're here for. And we are
Right.
your experts in that in a way, like, or if we don't know the answer, we're going to find out. We
Mm-hmm.
work with a team too. So if like, I don't know an answer, I have, 20 other nurses I can ask, or my doctors as well, to find the answer for you. But yeah, you're never going to know an answer if you don't ask a question, and you can't compare. The thing that's the hugest thing is, even if you're the same age, you think the same thing, that everyone is so different. Every cycle is so different. Like, every
Mm-hmm.
period is so different for females that you just can't compare. Like, your friend got 20 eggs. Well, you might not have that many eggs to get. So it's just like very huge to, again, talk with your friends and see what they're doing. I think that's great, to have those discussions, but also, relay that with your nurse or your doctor and have those questions asked, and make sure that a medical professional is like advising you on what to do, and that you never do something like start a medication or do something without talking to your nurse or doctor first.
Perfect. Well, thank you so much, Morgan. I
Yeah,
really appreciate it. This has been great.
yeah, absolutely. Well, I think
I'm
it's great what you're doing. I'm
gonna
very pro North Dakota getting on this stuff.
yeah,
But yeah, this was great. And yeah, if anyone has any questions, or you have any questions, you know where to find me.
perfect. Thank you again, Morgan.
Okay.
Have a good day.
Bye. Take care.
Bye.
Bye.